Hello everyone, my name is Kendra Mickens and I'm going to be presenting an unfolding case study on preeclampsia for you. This is going to be an unfolding case study for the advanced pathophysiology class taught by Dr. Foreman. First, we're going to start with a little bit of a background to the case, and I actually started with a little bit of information on preeclampsia first. Preeclampsia is a disease process that typically only takes place during pregnancy. When we look at it, it is absolutely dealing with elevated blood pressures, which we typically associate with a disease process such as chronic hypertension. However, preeclampsia, again, is a disease process that only takes place during pregnancy and typically does not take place until after the 20th week of pregnancy. Something that makes preeclampsia very different from gestational hypertension, which is also when a woman starts to develop blood pressure issues after the 20th week, is with preeclampsia, the woman is also typically spilling protein in her urine. And we're going to talk about those amounts a little bit later in this presentation. When we look at preeclampsia, also some of the things we look to see with hopefully this case study is that preeclampsia can be a very progressive condition where it's important for a nurse to be able to notice the changing status of a woman. And when we look at it, preeclampsia can progress to seizure involvement as well as lysis of red blood cells, elevation of liver enzymes, and a decrease in platelets, which is when we look at the lysis of red blood cells, elevation of liver enzymes, and decrease in platelets is associated with another condition called HELLP syndrome, which again can develop as a progression of preeclampsia. When we look at the term preeclampsia, if you look at it, it really is a breakdown of the word pre, meaning before, and eclampsia, which in itself is seizure activity. So preeclampsia is going to be prior to seizure activity. When we look at the importance of this condition, we see that maternal mortality is always a concern with pregnancy. It is a normal state, but there are some risk factors that come along with pregnancy. And we see that disorders associated with elevated blood pressures are the second leading cause of maternal death, and that is actually worldwide. When we look at it again, it is important to understand that preeclampsia can progress. It does not always progress. There are women who make it to term of 40 weeks. Without a progression of the disease and without them requiring to be delivered early. But again, this disease process can progress. When we look at the diagnosis of preeclampsia, it again typically occurs after the 20th week. And one of those things that makes preeclampsia also different from chronic hypertension, we typically associate with blood pressures, typically 140s over 90s consistently as being chronic hypertension. However, in pregnancy, if a woman's blood pressure after the 20th week increases at least 30 systolic or 15 diastolic over the baseline, that is also going to be a part of the criteria for her being diagnosed with gestational hypertension. And if there is protein in the urine with even an increase of 30 systolic, 15 diastolic, she is going to be diagnosed as preeclamptic, which is again very different than when we're dealing with the general population. So for example, if you have a woman whose baseline blood pressure was 90 over 40, her blood pressure could then go up to, say, 130s over 80s. And that typically wouldn't be indicative of high blood pressure, but in this case it would be. So very different in pregnancy. When we look at preeclampsia, there are also varying degrees of severity. So depending on the severity, there's a need to manage both not only the blood pressure of the mother, but also, again, preventing possible seizure activity. So when we're going to look at it, we're going to kind of look at that balance. And we see antihypertensives such as labetalol have been used to manage blood pressure values, while magnesium sulfate has been used to increase the threshold for seizure activity, in which magnesium sulfate is not primarily used to actually decrease the blood pressure. It is primarily used, again, to prevent seizure activity. So it's, again, that balance, because this woman will still typically need to have antihypertensives. When we look at studies such as those by Cassie, Noguchi, and Ahmed, we also have to look at that management of which should be a prioritization. So should it be the magnesium sulfate to control seizure activity? Should it be aggressive use of antihypertensives to make sure that the blood pressure is lowered? So those are some of the things that we're looking at. So again, while antihypertensives and magnesium sulfate are used to treat the symptoms of preeclampsia, ultimate treatment of preeclampsia is the delivery of the baby. That we typically know. So again, it's going to be that constant management of the woman's signs and symptoms, and also her laboratory work to see, are we reaching that point where, again, when we always in the medical field are looking at the risks versus the benefits. Do the risks of her staying pregnant outweigh the benefit potentially of her being delivered? So that's going to be a constant thing that her doctors have to manage during her care. So when we look at it, this condition requires vigilant observation, again, of both the physical data provided by the patient via physical assessment, as well as her laboratory data. And then we see the volume of protein in urine, CBC, platelet count, liver enzymes are all values that need to be monitored on a woman with preeclampsia. And again, this case study will follow a day in the life of a patient with preeclampsia. When we look at the overall goal of the study, it is for students to be able to identify worsening symptoms of preeclampsia and implement appropriate nursing interventions to manage the disease process. Again, as preeclampsia is a disease process that can evolve, being able to pick on the signs and symptoms that things are potentially getting worse are going to be of great importance. Our target audience is going to be associate level or baccalaureate level RN students. And we're going to look at the learning objectives and outcomes for these students. So when we look at it, we of course want them to be able to have assessment skills for preeclamptic patients. They should be able to assess risk factors for worsening signs and symptoms of preeclampsia. They should be able to verbalize the impact of medication on the progression of disease, including the effects in particular of magnesium sulfate therapy and the adverse effects associated with magnesium toxicity. They should also be able to utilize the SBAR-Q, or situation background assessment, recommendations and questions to communicate the changing needs of the patient. That's going to be primarily used with communication to the primary physician, but a lot of times it can also be used nurse to nurse in communicating what's going on with the patient. With our competencies, we're looking at patient-centered care, completion of focused assessment. Patient safety is always going to be a concern, critical thinking for application of knowledge regarding disease process, patient safety, application of pharmacology to disease process and evaluation, again, of that medication use, and then teamwork and collaboration, communicate with family healthcare team members as needed to provide care for the patient. So when we look at these learning outcomes and competencies continue, let's look at the critical case content to include as well as the critical activities to include. So when we look at the content, clinical guidelines for care of patients with preeclampsia. Again, we kind of talked about a little bit of reviewing the differences between chronic hypertension, gestational hypertension, preeclampsia, superimposed preeclampsia, eclampsia, and then the HELP syndrome. Key interactions between family and healthcare workers, inclusion of statements by patients, change in patient condition, assessment or reassessment needs, IV pole, IV pump, and in this case, electronic fetal monitor will all be used as equipment. Important decision making and clinical reasoning points, discussion questions to prompt the thought process of these students. And then when we look at the critical activities, caring as the art of nursing. So what is the nurse's interactions going to be with the patient in this scenario? Communication, again, between nursing staff, medical staff, and the patient and family. Customer service, a documentation of care, ethical, legal judgments, consequences. Of course, as we alluded to before, patient safety, prioritization, SBAR reporting, and teamwork. So let's look a little bit at our case opening. When we look at the background to the case, in this scenario where we're just doing an unfolding case study that could be used in the classroom, we have a minimum number of characters, with Gigi being our 41-year-old African-American female patient, who this is her first pregnancy. She has never been pregnant before and therefore hasn't delivered any other children. And she's presently at 34.2 weeks pregnant. And then her husband is going to be BG, and is her husband of 5 years. And then also in this scenario, you're going to notice that we talk quite a bit about the nurse's assessment, in this case, a high-risk OB nurse's assessment of her. And this nurse happens to have 20 years experience. The setting is going to be a high-risk obstetric unit located in an urban hospital. And here's our situation. So Gigi is an African-American and has reached her 34th week of pregnancy. She's presently 34.2 weeks in her first pregnancy at age 41. This would be the first child for both Gigi and her husband. Gigi did not have any significant medical history prior to her pregnancy, nor did she have any history of surgical procedures. Gigi does have a family history of hypertension of both parents and both sets of grandparents. Going back into her obstetrical history with this pregnancy, at 24 weeks, her blood pressures did increase to consistently 150s over 100s with 2+ protein noted in her urine. Very typical of if this were to occur at an office visit. Gigi was then asked to do a 24-hour urine, which revealed she had 350 milligrams of protein in her 24-hour urine. So the patient's blood pressure levels did not decrease with bed rest, and she was started on labetalol, 200 milligrams 3 times a day, in which labetalol is an antihypertensive. With the introduction of this medication, we can see that it was able to bring her blood pressure down to a range of 130s over 40s to 80s over 90s. Typically, primarily in the initial part of dealing with preeclampsia, of course, we would like to manage that blood pressure first. At this point, we see Gigi comes in for weekly obstetric appointments in which she receives weekly non-stress tests, which is typically where the woman is connected to electronic fetal monitor for at least 20 to 30 minutes to look at reactivity of the baby and look at fetal well-being. And we see this case follows what happens at one of Gigi's weekly OB appointments. So when you look at her vital signs, her pulse is fine at 85, respiration is 20, temperature is 98.9. However, her blood pressure today is 166 over 98. Her O2 saturation is 98% on room air. Her medications, prenatal vitamin daily, Colace 100 milligrams as needed for constipation, and again, her labetalol 200 milligrams 3 times a day. When we look at some of her lab values, her hemoglobin is 11, hematocrit is 30, platelets are 150. When we look at some of her liver enzymes, they're normal at 35 and 20 with a serum creatinine of 1.1. And again, when we look at that 24-hour urine that she did, the protein value was 350. So let's get into our case. So Gigi, again, at 34.2 weeks, is pregnant for the first time, but however is now being sent to the hospital to be monitored after having 2 abnormal blood pressure readings at her regular weekly scheduled OB visit. She was diagnosed, as we previously said, with preeclampsia at 24 weeks. The patient had 2 blood pressure readings in the office of 160s over 90s and presently takes labetalol 200 milligrams 3 times a day. The patient is asymptomatic in that she is denying any headaches, visual changes, or epigastric pain. Fetal movement is noted and patient denies any contractions. Fetal heart rate is in the 150s and her reflexes, deep tendon reflexes, are 2+. When we look at this, the critical thinking questions I pose to the students are: what are the risk factors for preeclampsia? What is the diagnosis criteria for preeclampsia? And why would Gigi's doctor's appointments be once a week at 34.2 weeks? So some of the things that we're looking for the students with this one, some of the risk factors, especially when we look at Gigi's case, is that she is African American, she is over 40, and this is her first pregnancy. Other risk factors are also if a person has had a molar pregnancy, a history of chronic hypertension, if she's ever had a history of delivering or being diagnosed with preeclampsia before with a previous delivery, obesity, and smoking. When we look at this, again, Gigi has quite a few of those factors, even with the absence of her having hypertension previously or with her having a previous history of preeclampsia. When we look at the diagnosis criteria, I kind of touched on that before. For her, her blood pressure is kind of skyrocketed at 24 weeks and was well past 140s over 90s consistently. And then she had that 350 milligrams of protein in her urine. So typically after 20 weeks with consistently high blood pressure and the spillage of protein, she is going to be diagnosed with preeclampsia. And again, when we look at the doctor's appointments being once a week, again, with the potential of progression of this disease process, a lot of times at 34 weeks, sometimes earlier, 32, women are seen weekly to monitor the potential progression of this disease and to also look at the fetal well-being of the baby, which can be greatly impacted as this disease process potentially worsens. Moving on to the unfolding case study change number 1. So when we look at it, Gigi has been on bed rest while at the hospital and was given a dose of labetalol at 1500. So again, this is going to be her second dose for the day. She was already taking it 3 times a day. It is now 4 p.m. and there has been no improvement in the blood pressure. The nurse performs another assessment in which Gigi is now reporting a headache of 4 out of 10. She continues to deny visual changes or epigastric pain. She continues to note fetal movement and the fetal heart rate is 140. Gigi's reflexes are 3 plus, clonus is absent. When we look at these new critical thinking questions that are posed, we're looking at why is the patient taking labetalol? Is there any significance to the patient reporting a headache? And if yes, explain. And what would you anticipate as the next interventions by the nurse due to Gigi's 3 plus reflexes? When we look at it, of course, we kind of touched on the fact that labetalol is an antihypertensive, and at its core, preeclampsia is marked by elevated blood pressure. So they always want to manage the blood pressure first. And Gigi's blood pressures were excessively high with her being 150s, 160s. They do like to get it down to at least the 130s, 140s. And previously, previous to today, her labetalol was managing that. When we look at the significance of a patient reporting a headache is a common symptom, of course, with high blood pressure issues anyway. And this is significant only because Gigi previously, as she was admitted to the hospital, didn't have a headache. So this is something, again, anyone can get a headache, but it raises our eye with her history as something we need to keep an eye on. When we look at interventions we would anticipate with the 3 plus reflexes, again, this is a change in Gigi's status. Actually, when we look at preeclampsia, again, there's always that present concern of neurological involvement in the progression to eclampsia where there's seizure activity. So that is something that I would anticipate that the nurse may go ahead and institute things that would not require a doctor's order for reducing stimulation. So turning the lights down in the room, possibly putting Gigi on her side, because a lot of times laying on your side is associated with also lowering the blood pressure. And again, definitely something where I would anticipate that this nurse is going to relay this information to the physician. So when we look at how this case study continues to unfold, so it looks like the nurse does encourage Gigi to lay on her left side and turns the lights off in the room. The nurse then contacts the doctor and informs them of changes in Gigi's status. The patient is given a 4-gram bolus of magnesium sulfate and started on a maintenance drip of 2 grams of magnesium sulfate. The room is kept dimly lit with the patient's husband now at her bedside. Gigi's blood pressure spikes to 200 over 100 despite all the interventions applied. Her reflexes are now back to 2 plus. And when we look at it, the preeclamptic labs are ordered and drawn. Gigi is given her first dose of betamethasone and is advised of plans for her delivery. Our new critical thinking questions to our students are: using SBAR-Q, what should the nurse include in the communication with the doctor? What is the impact of magnesium sulfate therapy on the progression of preeclampsia? What is the desired magnesium level for those receiving magnesium sulfate? What is the antidote for magnesium sulfate? And why was Gigi given betamethasone, and how many doses will she be given? So, of course, SBAR-Q and just how we communicate with each other is very important. So it is important to reinforce to the students, talking about the situation, the background for Gigi, the nurse's assessment, again, all these interventions that have been done. The one positive is that Gigi's reflexes seem to be back to normal with the institution of the magnesium sulfate. However, her blood pressures are not being managed with the labetalol. And again, when we look at the magnesium sulfate, its primary use is to increase the seizure threshold, not to lower her blood pressure. So it looks like that is the main thing that we do not have control of at this time. When we look at those are definitely things that we had to communicate to the doctor, and are anticipating also communicating those laboratory values when they're back. When we look at the impact again of the magnesium sulfate with the progression of the preeclampsia, again, we're hoping to keep it from progressing to the eclampsia, where she would have seizure activity. And then we look at the desired magnesium level. A lot of times resources will say 4 to 7, which is actually outside of the normal magnesium range. So a lot of times laboratories will call nurses to let them know that it's the elevated level, but nurses are aware that it's within normal range for magnesium sulfate therapy, especially for something like management of high blood pressures. The antidote, again, that we're looking for is for these students to know, and it's a have to know, that anyone on magnesium sulfate therapy will need to have calcium gluconate, which is the antidote, on hand at all times. And then we actually see in Gigi's case, she's moving toward potential delivery. So the doctor is prophylactically administering betamethasone, which is going to be a steroid, typically 2 doses that are given, so that we can have actually acceleration of fetal lung maturity, since Gigi, of course, is not term at this time. So for closing the case, Gigi is able to give birth to a healthy boy via primary C-section. She remains on magnesium sulfate therapy, and vital signs are being monitored every 15 minutes. Gigi's husband remains at her bedside, but has a number of questions regarding how things progress so quickly, and if this is something they should be concerned with if there are additional pregnancies. So new critical thinking questions: why was Gigi delivered? Why is Gigi remaining on magnesium sulfate therapy? And are the dangers of preeclampsia gone now that Gigi has been delivered? So of course, we already alluded to the fact that, ultimate treatment of preeclampsia is going to be delivery. In this case, while Gigi's deep tendon reflexes did return to normal, the concern was all of the adverse effects that she could face with that high elevated blood pressure reading. With such a blood pressure reading, there's going to be some level of uteroplacental potential insufficiency, which could be a danger to the baby. So with her involvement of the CNS, with us knowing that her reflexes were changing, and the inability to maintain a safer blood pressure, again, a lot of times it is going to be to deliver the patient. When we look at it, why is she remaining on the magnesium sulfate? It becomes a little tricky if we look at it and we think that delivery is the ultimate cure or treatment, but the risk for her still progressing to eclampsia is still very present after delivery. It takes the body a couple weeks to adjust. But typically after those couple weeks, that is when she would be out of the woods for developing eclampsia. And of course, with that, it rolls into question 3: are the dangers of preeclampsia gone now that she's been delivered? They're not completely gone, because again, there is that adjustment period for the body. When we look at the debriefing questions to the students, looking at the things of reviewing concepts, interventions, patient family responses, and discharge planning. Some of the things I proposed, or how would you best answer Gigi's husband's question regarding his wife's progression of preeclampsia and her risk of preeclampsia with future pregnancies? Well, of course, this is a disease process that, while predictable, we cannot always say who it's going to progress on, how it's going to progress. We do understand what the progression can look like. The speed of it, we don't always know, but it is always a very real factor with a condition like preeclampsia. And of course, we do know that a previous case of preeclampsia is actually a risk factor for preeclampsia or future pregnancies. Also, the fact that Gigi will be older, will still be African American. All of those, again, compound now her risk factors. Again, while her blood pressure issues should resolve after her pregnancy, there is also still a chance that they don't, and that would be then another risk factor for having preeclampsia with an additional pregnancy. When we look at what should be included in the discharge planning, of course, it's going to be all of the things regarding signs and symptoms of preeclampsia. We always like to know about the presence of headaches, any visual disturbance, and the presence of epigastric pain. And then because she had a C-section, which is not always required for a person who has preeclampsia, but with her worsening blood pressures, the stress of actually laboring could have been thought of more of a hazard than a benefit. So she still needs to know about pain management, which we also know can have an effect on blood pressure, care of the incision, making sure that she doesn't develop an infection, UTI-wise because of possible catheter placement, and then definitely wound infection is always going to be a potential. She still needs to know, depending on whether she's breastfeeding or not, the importance of her increase in calories for breastfeeding, proper care of her breasts, and again, the process of involution that her body's going to go through at the delivery of a baby. When we look at her questions, we have to look at the questions for the students and actually getting an idea from them after they've learned about these disease processes, chronic hypertension, gestational hypertension, preeclampsia, eclampsia, HELLP syndrome. In this particular case studies, did the events progress as they suspected? Did they move slower, faster? What did they learn today? Also reviewing the differences between, again, chronic hypertension, gestational hypertension, preeclampsia, superimposed preeclampsia, which is, again, if a woman already has chronic hypertension and then becomes pregnant, eclampsia when there can be seizure involvement, and then HELLP syndrome. And then discuss the effects of magnesium sulfate therapy and the adverse effects. A lot of times in this particular scenario, Gigi had a desired effect. Her DTRs were 3+, and with the inclusion of magnesium sulfate, they came back into normal range. However, when we are using magnesium, there's always the risk of respiratory depression. There's a risk that her DTRs could go down to 0. We're always concerned about urinary retention. So we always have to monitor those I's and O's. So while we are looking for the benefits of magnesium sulfate therapy, there is such thing as magnesium toxicity, which is why we also do such frequent magnesium levels, just to make sure there's not any signs and symptoms of toxicity from a lab value, in addition to looking at the physical assessment. And again, that need to have calcium gluconate on hand at all times. We do have to discuss the risk of the patient after delivery because, again, although that is considered treatment, her risk of developing eclampsia in the postpartum period is a very real risk. And although she is delivered, she could then have seizure activity. So she has to be educated on that fact and, again, aware of monitoring her blood pressure at home and looking at those signs and symptoms, headaches, visual changes, epigastric pain. And then again, we just have to have appropriate time to accommodate students' questions that they may have. They may need to figure out preconceptions that they may have had that either did go along with this particular case or did not go along with this case. And then when we look at the instructor resources and instructions, again, this particular one was looking to be delivered at associate level or baccalaureate level pre-licensure students for nursing students. When we look at it, we could use the unfolding case study to promote critical thinking and reinforcement of the education regarding preeclampsia. Props would include, again, an IV pole, IV machine, along with an electronic fetal monitor. And then, again, if we're actually going to use this in simulation, we could always hopefully have Noelle, who is a birthing mannequin. And when we look at this case study, again, we're going to talk about the fact that it could be used either in the classroom or in a simulation setting. So in the classroom, students can work in teams of 2 to tackle the unfolding case study. And then in groups of 5 for simulation. In a simulation, each student would be assigned one of the following roles, and you'll notice that I added some from the original one from the classroom setting. So we still have Gigi, the patient, and her husband, but I'm now adding a triage nurse, and this will add a different dynamic of now having an example of a triage nurse from the office giving report to the high-risk OB nurse in the hospital, who's going to be getting that patient. And then we could also have a labor and delivery nurse for a different dynamic of dealing with Gigi during her labor and delivery process. For additional resources, both ACOG and the National Institute of Health have patient information regarding preeclampsia. And if we look at it, the printed material can be made available to the students to use as a part of education to Gigi and her husband, as well as a part of the debriefing. And these are my references here. So I hope you enjoyed my unfolding case study. And thank you all for listening. Thank you.